My name is Cray Bolger, one of the ultrasound faculty at Ohio State University. Today we will be discussing how to perform the hepatobiliary scan. As with any scan, we begin with eye aim. Why are we doing the exam? How are we going to acquire the pictures? And how will we apply the images we obtain to our patient's clinical picture? For the right upper quadrant exam, the indications are pain in the right upper quadrant, abnormal LFTs, or any unidentified sepsis, or any patient with sepsis with unidentified source. To perform this exam, both the curvilinear and phased array probe are appropriate. Before doing this exam, ideally your patient should lay supine. However, if they are unable to tolerate this secondary to pain or other situations, they may be examined in a semi-upright or lateral decubitus position. In addition, if you are unable to find the gallbladder, the patient may be placed in the left lateral decubitus position, bringing the gallbladder closer to the anterior abdominal wall and displacing the bowel gas. We will review the protocol of long axis with sweeps and short axis with measurements. To begin, the provider places the probe with the leading edge in the subxiphoid region of the body facing cephalad, and then sweeps lateral, keeping the probe perpendicular to the patient's body. To do this, they will interrogate the aorta, then the IVC, and the third anechoic structure they will encounter will be the gallbladder. Once they are in this region, the provider will then fan through the gallbladder, interrogating it in the long axis, paying careful attention to the gallbladder neck, as this is a common place for stones to be lodged and missed. First, we'll review some gallbladder anatomy. The gallbladder is anechoic and fairly superficial and resides just inferior to the liver, noted here as a hypoechoic landmark on the leading edge of the probe and the cephalad portion of the body. The portal vein is just deep to the gallbladder and also anechoic with hyperechoic walls. The duodenum is just deep and inferior to the gallbladder. This can often be confused for the gallbladder when there is fluid within the duodenum. The portal triad is a common landmark for both the gallbladder and common bile duct. The portal triad can be found by looking for the MLF, which connects both the gallbladder and the portal triad. Here's the gallbladder. Here is the hyperechoic MLF, or main lobar fissure. The portal vein is the large anechoic circle, also known as the face of Mickey Mouse. The common bile duct is Mickey Mouse's left ear in this view, and the hepatic artery is Mickey Mouse's right ear. To tell the difference between the hepatic artery and common bile duct, the provider may place colored flow over the portal triad. The ear without flow is the common bile duct. Once the provider is done interrogating in the long axis, they will rotate the probe 90 degrees with the leading edge towards the patient's right and fan through the gallbladder in short axis. Please note that for both the long and short axis imaging of the gallbladder, the provider is up on the costal margin. A common error is placing the probe too far down into the stomach, where all your views will be obstructed by bowel gas. Again, just as with the long axis, it is important to fan all the way through the gallbladder, looking for stones, especially lodged at the neck of the gallbladder. There are many anechoic structures in the right upper quadrant: the portal vein, the IVC, the aorta, the gallbladder, and the hepatic vessels. The gallbladder is the only one of these, outside of the common bile duct, that will not have flow within it. Placing color Doppler over these structures will help the provider to identify the gallbladder. When obtaining measurements, gallbladder wall should be measured in the short axis on the anterior wall. This will give you the most reliable measurement. A normal measurement for this is 3 millimeters or less. Note how hyperechoic and thick the posterior wall is. This is secondary to posterior acoustic enhancement from the waves being unobstructed as they travel through the gallbladder. By measuring the posterior wall, the provider may get a falsely elevated number. For the common bile duct, the provider will find the portal vein and long axis and place color flow over it. There will be a small anechoic tube just anterior to the portal vein with no flow in it. This is the common bile duct. The common bile duct should be measured inner wall to inner wall. A normal measurement for the common bile duct is 4 millimeters or less. This will be corrected for age and cholecystectomy. Some common findings and pathology in the right upper quadrant include gallstones. In a distended gallbladder, gallstones will be noted as a hyperechoic region within the anechoic gallbladder with a dark shadow behind them as seen here. Remember, as we mentioned before, gallstones can often be missed when they are lodged in the neck of the gallbladder if it is not thoroughly interrogated. Occasionally, the provider will encounter a patient who has recently eaten. In this case, the gallbladder may be contracted, in which case we will not find a large anechoic structure in the right upper quadrant. The West sign is a common finding of gallbladder pathology. West stands for wall echo shadow. This is when a normally dilated gallbladder contracts around a stone and one may not see the anechoic fluid but rather just the wall of the gallbladder, the large hyperechoic stone, and the shadow behind it. Another finding of cholecystitis and gallbladder pathology is wall thickening. As mentioned before, we measure the gallbladder wall in the short axis in the anterior wall. Anything over 3 millimeters is considered pathologic. In addition, small amounts of pericholecystic fluid are also indicative of infection. Occasionally, sludge will be seen in the gallbladder rather than a stone. This will be much more hypoechoic than a stone and will not have as much, if any, shadowing behind it. This still can cause pathologies of the gallbladder and should be taken seriously. How do we apply these findings? If pathology is identified, the next question you must ask yourself is, does the patient have a sonographic Murphy's? A sonographic Murphy's and positive findings in the right upper quadrant ultrasound are fairly sensitive for cholecystitis. Remember that there are many things that can cause a false positive in the right upper quadrant, one of which is free fluid in the abdomen. Any free fluid in the abdomen can track up into the right upper quadrant, causing a false positive pericholecystic fluid and also falsely thickened wall. In addition, if the patient has recently eaten, when the gallbladder is contracted, the gallbladder wall may appear falsely thick. Polyps can often mimic stones, and thus, without a shadow, the patient should be asked to roll onto their side to see if the structure is fixed or mobile. Stones will be mobile, whereas polyps will be fixed. In summary, ultrasound can be used to reliably diagnose much of the gallbladder pathology. Remember that normal gallbladder wall, measured in the short axis anterior wall, is 3 millimeters or less, and normal common bile duct, measured inner to inner, is 4 millimeters or less. However, this will be corrected for age greater than 40 and if the patient has had a cholecystectomy.